So, good evening, everyone, and a very, very warm welcome to today's evening. And this is our fifth week, consecutive week that we had been, doing these sessions around medication safety. And I'm very happy, and we are very glad that many of you have joined us after week, and some of you are using the recordings which are available on our YouTube to share with more of your staff and students. So thank you so much. Whatever that we do for patient safety will always remain less because there is so much that we need to do. So this year, WHO has given the theme medication without harm, and they have released multiple technical reports. So that's how we started with medication safety challenge, and then we discussed about high risk situations where we discussed high risk medications, and then we followed it up with the risk that is involved during transitions of care, and the last week we discussed about polypharmacy. And this week, we are going to end this series with very relevant and a very practical topic, that is safe medication practices for administration practices for nurses. And we know that nurses are the fag end of the entire chain of medicine. That's when nurses are administering the medication. So today we have got a young nurse doing the session for Cygnia Healthcare, and I'm very proud to introduce her. That is Lincy Jesvin. She's an MSc nurse, graduated in 2008. She's a critical care nurse, and she had been a lecturer, she had been a clinical educator, so a combination of many things. And I'm very happy, Lindsay, you're here, and thank you so much for being here. And I'm also very proud that I'm able to find someone like her who has got the right passion and the right place, along with the talent that God has given her to translate knowledge into simple language so that everybody can understand. So thank you very much. And Lindsay, I'm going to set the context by playing a short video before you start your session, right? Okay, so let me just get that presentation up, and we will start with a warm welcome to all of you once again. And Cygnia Healthcare is committed to patient safety, and that's right, pursuit of patient safety. And we had started this series from last year, and we are very happy that we have a lot of free sessions under this umbrella. All of them are available on Cygnia Healthcare's YouTube, and some of them are also available on our learning management website, which is cygniahealthcareacademy.com. So some of them, they do give certificates. If you go through the videos and do a post test, you will get a certificate. Even for these 5 series, we are contemplating that we will put them on our academy site, and probably we will create a post test around it, so that people can seriously watch the video, learn something from there, and even get a certificate, e-certificate, is possible. So today, as we are going to discuss about the safe administration practices for nurses, I'm going to play this video. If I start looking for anything from India, it is very difficult to find anything. So whatever that we have are all from abroad, because they are far more uh, forthcoming when it comes to sharing the mistakes that have happened, and they creates, actually they ask the parents and in the family to share, so that the caregivers can understand the kind of harm and the agony the patient family and relatives go through. So let me show you this story as well, and then I'll be handing over to Lindsay to take today's session. So this is a very short video, just give me just about 3.5 minutes. That's it.
I'll never forget the day that my 4-year-old son Logan almost died in my arms in Royal University Hospital. We were sitting on his hospital bed when he let out a scream. And I knew that he shouldn't be screaming because he shouldn't have been in any pain.
A bag of potassium that was a concentrated, heavy concentration bag was hung instead of a diluted bag.
As a pharmacist, I know that when the concentration of potassium is too high, that it can burn. So I knew when I looked behind me and saw potassium hanging that the concentration Logan had been given was too high for him, and as a result could have killed him. I immediately locked his IV and I started to cry and shake with all the chaos going on around us.
I went over to the bedside and saw that she clearly was upset about something.
And he looked right at me and he said, "I have no idea what you're talking about, but I trust you and I know that you know there's something wrong. I'm here to help. Let's figure this out."
We rolled Logan down to the OR waiting room where we met up with the anesthetist. And come to find out, he didn't even know that Logan had a kidney condition. He wouldn't have required us to increase the potassium if he had known that in advance.
May I request everyone to keep your audio muted, please, so that others can uh, watch this, peacefully. Otherwise, I will be forced to mute everyone at one go. Please. So I'm going to start a little bit from behind because there was a lot of disturbance. Lindsay, I will request that while I am playing the video, admit people. Yeah. Thank you.
His IV and I started to cry and shake with all the chaos going on around us.
I went over to the bedside and saw that she clearly was upset about something.
And he looked right at me and he said, "I have no idea what you're talking about, but I trust you and I know that you know there's something wrong. I'm here to help. Let's figure this out."
We rolled Logan down to the OR waiting room where we met up with the anesthetist. And come to find out, he didn't even know that Logan had a kidney condition. He wouldn't have required us to increase the potassium if he had known that in advance.
I firmly believe that everybody that day was working with my son's best intentions. I work in the system myself, and I saw errors. I've been involved in errors before, but the way Saskatoon Health Region handled this error has been incredible to watch. Their openness to understand that there are safety defects in the system and their openness to work with me and to try to fix them have been unlike anything I've experienced in my own healthcare career to this point.
The most important thing that I learned from this whole experience was that, first of all, we as healthcare providers need to talk to each other. We need to be able to listen to the families. If we are in a situation where we're not sure what's going on and we're not comfortable with the situation, we can't be scared to just push the stop button and figure out together what's really gone wrong.
Safer Every Day is a 90-day initiative where we are focused on improving safety for patients and our staff. One of the areas of focus is on team communication. We're really working on how to help teams communicate, including the patient and family, in a way that keeps everyone safe. The other area we're really focused on is how do we support both the patient family, the staff, and the physicians who are involved in events like Logan's, so that they feel supported after the event, that we all learn from the event, and that we work together to put in initiatives or improvements that make our care safer every day.
I was devastated when I heard Logan's story, but I also know that unless we figure out how to work differently and build safer systems, that what happened to Logan could happen again.
So friends, thank you. So that video was just to help to set the context, and I'm sure that Lindsay is going to talk about most of the things that has been discussed in the video as well. But this video is from abroad. This is not from India. So obviously, we need to come to India, discuss about what can be done in our country with our nurses, because patient safety is same across the world. So we have so much to do, and we are doing a little bit from our side to help our nurses and students to be more aware so that they can play the role of safety champions wherever they are. Thank you so much for being with us. And thank you, Lindsay, and over to you now.
Thank you so much, ma'am, for the introduction and for the amazing video. It was very refreshing, and I think it is going to support what I'm going to speak today. It's an honor to be here and associated with Cygnia Healthcare and work with Madam Tangam, because she is a visionary, she is a change maker, she's a passionate nurse leader who wants to make a nurse's safety champion. And that's why we are doing these series of WHO sessions. And in fact, she was supposed to do the 5th session as well, but she's very kind. She gave this opportunity to me and I took it. So thank you so much, ma'am. Thank you everyone for being here. I know your time is precious and you being here means a lot to me. So let me share my PPT without further delay. All right. So let us begin. In pursuit of patient safety. So we are going to talk about more about medication safety, which would be connected more with the staff nurses, with nurses who are directly involved in administration of medications. So welcome once again. Good to see. In fact, I don't see anyone, but good to have you all here. Right, so before, so we are doing safe medication practices for nurses. So before we begin with the topic, I would like to show this picture to you all. Okay, so this has no connection with medication safety. But what I want you all to do is, you have to find out 5 mistakes in this picture. Type it in your chat box and send it across. And you have 1 minute to find out the mistakes. Remember, there are 5 mistakes and you can put it in the chat box if you find them. And let me see if you're able to find it out. Okay. Is anyone able to spot anything that's wrong? Cat clothes? No, the cat is not wearing any. In fact, it's not wearing. Yes, that's right, Rini. Shoes are kept on the rack where plates are supposed to be kept. The cat is eating the bone. Yes, Kevin, you are right. Oh, high heels, ma'am. Good one. Yes, the globe is kept near the dustbin area. Correct. Under the basin, right? Not the dustbin. Under the basin, next to the dustbin. Correct. 2 more. If you could find 2 more. Shirt, yes, the shirt is hanging near the window. Yes, clothes on the window. Good. Yes, Abhi, Steffi. Yes, Kevin, you're right. 1 more, 1 last, if you could. That's right, Arsha. Instead of a tap, instead of a faucet, there is a light to it. Very good. I am so glad. Less than a minute, you were able to find out the 5 wrong things with this picture. So I'm glad that your eye for detail is intact and you're paying good attention. So thank you so much for participating. So let's move on to our topic today. So the objectives of today's class would be to know the factors that influence medication errors. So what are the factors that commonly cause medication errors? We will see what are the risks of harm to patients during medication administration. We will review the basics, what you basically do on a daily basis. We will also go beyond basics. Like I would give you extra tips to improve your medication practices. I will talk in brief about personal accountability, which is very important, and nurses as the last line of defense. Now, let me not scare you by these huge terms. I'm going to keep it very simple, very basic, so that you understand and you gain maximum from this class. Okay. So before we begin with the factors, let me just quickly read what medication errors are. So according to the definition, medication errors are any preventable event that may cause or lead to inappropriate medication use or patient harm while the medication is in control of the healthcare professional, patient, or consumer. So that's the definition, right? So let me just go through this chart. I am sure many of you use this chart in your hospital. So this is for the ones who have not seen this chart before. This is by the National Coordinating Council for Medication Error Reporting and Prevention. So I will just go through each category. So there are from categories A to I. Category A means circumstances or events that have the capacity to cause error. For example, if you are working in a high risk area, or if you have vulnerable patients under you, the risk of committing a medication error is higher. So identifying that circumstance or identifying that situation and being alert is category 1. Now in category A. So category A means just identifying just the circumstance that is around, but the error has not happened. In category B, C, and D, you see that an error has occurred, but it has not caused any harm to the patient. So let me go with category B first. In category B, it says an error occurred, but the error did not reach the patient. For example, the act of omission. You're supposed to give a nebulization to the patient, but you forget it. So you have omitted that drug. You have removed that. I mean, you forgot to give that drug. You missed that drug. So the drug has not reached the patient. So that comes under category B. Category C means an error has occurred that reached the patient but did not cause patient any harm. For example, your doctor has prescribed pantoprazole 20 milligrams for your patient, but you accidentally take pantoprazole 40 mg from your stock and administer it to the patient. So it's not going to cause much of a side effect. It's not going to cause much patient harm because it's a general drug. It doesn't come under high risk or LASA. So the error has occurred, but the patient has not had any harm because of it. Category D means an error occurred that reached the patient and required monitoring to confirm that it has resulted in no harm to the patient and required no intervention per se. For example, in category D, so for example, your patient has received some medicine, and you don't know this. I mean, there is no visible side effect, but in case any side effect happens, you need to monitor the patient. For example, if it's a high alert drug and little bit of dosage has gone up or down, you need to monitor the patient in that matter. So it comes under category D. Category E means an error occurred that may have contributed to or resulted in temporary harm to the patient and required intervention. For example, I remember a situation where a nurse was administering Tramazac to the patient. It's a pain killer. And he did not know that it is supposed to be diluted. And he was about to he pushed the Tramazac to the patient, and patient ended up having severe vomiting and GI upset. So there was temporary harm to the patient. The patient ended up vomiting. He had bouts of vomiting, but then we had to monitor the patient. There was temporary harm. There was fluid loss. So we had to monitor the patient and provide IV fluids to the patient. So that comes under category E. Category F means an error has occurred that may have contributed to or resulted in temporary harm to the patient and required initial or prolonged hospitalization. Suppose if the fluid loss was very severe and the patient required 2 extra days to stay in the hospital because of that drug harm, then that comes under category F. Category G means an error occurred that may have contributed to or resulted in permanent patient harm. For example, as ma'am was talking about a situation that happened abroad where a nurse, by mistake, she administered a muscle relaxant instead of an antidepressant, and the patient had severe side effects and permanent patient harm occurred here. Now, if that leads to interventions that require life-sustaining measures, like you are doing everything to sustain life, like basic life support, you are putting the patient on ventilator or anything, that goes in category H. If the patient dies because of that. If the patient succumbs because of medication error, that goes in category I. So you don't have to buy hard these categories, but it is good for you to know that these categories exist. And if an error occurs, you should be able to place the error in this circle. Okay. Mostly, we should be alert in category A and not wait for B, C, D, E to happen. But sadly, what happens is many errors happen around this category B or C, and we think nobody knew about it. It's okay. Let's just hush it. So we don't report these errors, and it never comes out because we hush it up, right? So we will see what influences these medication errors. Time to think. Common causes. I'm not going to talk anything hi-fi. Very common causes. High volume. When you have a lot of patient traffic, when you're receiving a lot of patient admission, or your ward is full, or your ICU is full, there is a tendency to be confused, to mix up medications, to mix up dosage, and you might end up committing a medication error. Poor handwriting, illegible handwriting. You're not able to understand the handwriting. The prescription is all messy, and you're not able to understand the route, the dosage. That can lead to medication errors. Inexperienced staff. I have a good example here. There was a dialysis nurse. She's been in the dialysis for 20 years. So once there was a patient staff shortage in the ICU, and she was sent there as a filler just to help around. And she had no experience with cardiac drugs. But it was assumed that she should know. She's in the hospital for 20 years. So the assumption that she should be knowing everything led to a serious medication error, because she did not know drug calculation. She did not know how dobutamine and dopamine works, and that led to medication error. So inexperienced staff. Also, the new nurses who come to the hospital, or when departments are you change from one department to another, and if you're not oriented or continually trained, that can lead to inexperience and further medication errors. Lack of appropriate monitoring. If your patient, I would request you to keep your mics muted. Thank you. If your patient is already having hypokalemia, and the patient is receiving Lasix, and you're not monitoring the patient appropriately, the patient might end up having severe hypokalemia, right? That happens because of lack of appropriate monitoring. So this can lead to medication error. Lack of policy enforcement. If your hospital has no proper policy in place, it's all confused, it's all messy, it's all incomplete, that can lead to chaos and confusion, and that can lead to further medication error. Next would be medications requiring calculations. To be honest, when I started my initial days of nursing, I struggled with medication calculation, because it was difficult for me to get into this calculation. Algebra, geometry, everything was difficult for me. So this calculation was so confusing. It took me a while's practice to get into, knowing different drugs and different calculations, and get the right answer. So if you are not very aware about different formulas and different ways drugs are calculated, that can lead to medication error. Verbal orders, poor communication. I still remember Madam had shared a story in the second session about a nurse who injected potentially fatal potassium to a patient who already had hyperkalemia, because he took verbal orders from his colleague. Okay, so verbal orders, poor communication, written or spoken, that can lead to medication errors. Stress. We take it so lightly. Oh, stress is everywhere. I mean, it's normal to be stressed out. But it's not normal to be stressed out. Stress can actually lead you to confusion, to lethargy, to fatigue, and you can end up having medication. You can end up committing medication error out of stress. Stress can also be because of the ICU or the environment you're working, the people you're working with, the management, the policies. Anything can lead to stress. Personal issues. Now, we are human beings. We have our families. We stay with people. we do have personal problems. There's not one person who wouldn't have a personal problem. There could be miscarriages, there could be divorces, there could be fights in the family, deaths in the family, personal issues that can crop up while you are on duty, and that can affect your functioning and lead to further medication errors. Shift work. Suppose if a nurse has just finished evening shift and she's asked to come for morning shift the next day. She has only this much little time to rest. She wakes up in the morning, she comes all restless, and the way she is, she just wakes up and comes for duty. She has not got enough rest. She's stressed out because of the morning shift, and that can lead to further errors. Okay. So these are some of the common causes. I have not included a wide list, but these are some of the common causes that can lead to that can influence medication errors. So if you see this graph, this is a data about medication errors in inpatient department in a place called Ethiopia. They were saying that they showed that this graph reflects that 87.5% of medication error was because of documentation error. Anything related to documentation, missing the dose, missing the time, missing the route, and illegible handwriting, giving the medication but not documenting, not giving the medication but documenting. So these all these factors come under documentation error. So 85% of the errors came under documentation error. Then you have technique error. For example, when you're giving an IM and you use a Z-track technique and it's not done properly, it comes under technique error. So similarly, we had many criterias, and you see that wrong timing 53.6%, dosage error 23.1%, omission of drug, that is missed drug 8.3%, wrong route 2.8%, and others 1.1%. Now you would ask me, Lindsay, we are in India. We are talking about nurses and the situation in India. Why are you presenting a graph from Ethiopia? So let me tell you one thing. We have hardly, like on our fingertips, we hardly have data from India, because what we do is we don't report it honestly. That is why we don't see a lot of data coming from India. Okay, that is why we have to extract information from outside, where medication error reporting is maybe not perfect, but it happens. They accept that it is something that happens, and it is sometimes inevitable, right? So that is why this is not an Indian data, but this is something that I can present. Also, another data shows that medication errors happen because of too rushed or busy environment. As I told you, the first point that I had presented was volume, high volume, busy environment, everything is in a rush. 78% of medication errors happen because of that. Poor or illegible handwriting, 68%. Missed or mistaken physician's order, 62%. Working with too many medications, polypharmacy, 60%. Similar drug names or medication appearance, LASA, 56%. So look at the rates, it is quite high. So what is the risk of harm that occurs to the patient? See, according to WHO Global Patient Safety, we have to reduce the level of severe avoidable harm related to medications by 50% over 5 years globally. But the only struggle with this is that we don't have strong data with us. What are we going to reduce to 50%? We don't have strong data, strong evidence that medication errors are happening for us to work on that, right? That's a sad part. Yes. So that's why, again, if you see, I'm presenting NHS data here, but something is better than nothing. So medication errors can cause a lot of risk and harm to the patient. Medication errors are, as you see, prescribing, dispensing, administering, monitoring, transcribing errors. And these can lead to either no harm or adverse drug reactions, or if it's polypharmacy, drug-to-drug interactions, lack of efficacy or lack of effect of the drug in your body, average patient adherence, and poor quality of life and patient experience, and sometimes death. So these are the risk of harm to patients. If you see this slide, an estimated 237 million medication errors occur in the NHS in England every year. kudos to them that they are so transparent about their reporting. 68.3 million errors, that is 28% of the total errors that are reported, are moderate or it causes serious harm. The estimated NHS cost of definitely avoidable ADRs are 9.5 million pounds per year, consuming 181,000 so-and-so bed days and causing 712 deaths and contributing to 1,708 deaths. So imagine the number of errors and the number of deaths and the consequences of medication errors, which is transparently displayed here. This is November 2017 data. Also, if you see, this was a data from an emergency department that was collected between August 1, 2009 to July 2010. So if you see wrong dose overdosage, 452 in number. So if you divide 452 divided by 12, like in a year, you would see an average of 37 wrong dose or overdose overdose happening in a month. Now that's a good data. Like we usually we highlight, oh, there were 2 medication errors, oh, there were 5 medication errors, but that's not transparency. That might not be very honest. This is honest. Wrong overdose, wrong dose or overdose, 452 in a year. Drug being omitted, 353 in number. Wrong drug, 269. Wrong dose or underdosage, 180. Extra dose, 140. Wrong route, 130. So imagine this is true reflection. This is the true data that is reflected here. And I would encourage that we also should be active in finding out the real data, the real number of errors that actually happen. And I will tell you what benefits we can reap out of that. So review of basics. Now, as I told you before, there are types of medication errors. There is, we have our prescription. The doctor prescribes the medicine. We have transcribing error, where the pharmacy personnel will receive the indent from you. He dispenses the medication. There could be error over there, and we receive the medication and we administer the medication. So I'm going to focus majorly on administration of medications because we directly are involved in that area. Although you should have eye for detail for all the other areas. Like if there is an error in the prescribing area, you should be quick to find out. If there is some error with transcribing or dispensing the medication to you in the ward and you see, oh, this is a different medicine, you should be quick to have that eye for detail. And then comes administration. Now you're the sole person who has direct contact with the patient and you are administering the patient the drugs. So that is why we are going to mostly talk about administration errors. So reviewing the basics, as I told you, because we are directly involved with administration of medicines, I would be talking about that. So what are the basic things that you follow when you are involved in medication care? First is you verify the drug. So according to the protocols and the policies of your hospital, you're supposed to, you receive the drug, you see what drug it is, you cross-check with your doctor's order, the route, the timing and everything, you verify the drug. You check for allergies. Some hospitals have red bands for the patients along with the UHID or whatever MRD tags you have. There are allergy tags also, and specifically the allergies mentioned. So you ask for allergies. One patient at a time. It's very basic to avoid mishap, to avoid confusion, to avoid chaos. It is basic to understand that you have to administer medication one patient at a time and not in a group. Like, oh, all the 10 patients in the ward are receiving pantoprazole. Let me load 10 syringes of pantoprazole and go and give it to the patient. Next, let me give the antibiotics. It doesn't work like that. You would end up causing error. So basic is to give one patient medication at one time. Then educating the patient. I am not very sure if this is done day in and day out, but it's very important and it's very basic to talk to your patient. We just enter the room, we make a beeline, enter the room, open the drawer, give the medication, leave. No, let's stop doing that. It is basic for us to talk to the patient about the medications that we are administering. In this way, we are sure that we are not making an error. The patient is clear what you are giving, you are clear what the patient is receiving, right? So these things come under basic. Last is following the 5 rights. Now I'm sure your hospital must be having 6 rights, 7 rights, 8 rights, 10 rights, and I have no problem with that. Good, good if you have these policies in place, but I'll be only talking about 5 rights to be followed. So this is a new nursing. It's not new, but I found it very interesting. It's a nursing mnemonic which says TRAMP, administering medication checklist, TRAMP. You know, the real meaning of TRAMP is actually a beggar or a person who doesn't have a house. And the other meaning, if you treat TRAMP as a verb, it means stamping. So please remember the acronym, the mnemonic TRAMP. T, the time that you give the medication. Check the order. When was it given the last time? And when are you giving it now? Like, what is the time that you're administering the medication? So time is absolutely important. Route, what is the route of the patient? What is the route of the drug? Is it oral? Is it sublingual? Is it IV, subcutaneous, IM, or whatever? Please check the route. Amount or the dosage. Check the medication sheet and see what dose the doctor has prescribed. That is the amount or dosage. Medication. What medication is this? Is this a LASA? Is this a high alert? Is it a general drug? Do I need to be extra cautious when I'm giving this medication? And last is the right patient. You know, you would be familiar with the patient, but please have the habit of following up that this is the same patient, this is the right UHID, I'm administering the right medication to the patient. So TRAMP, this is something you remember. Apart from that, you can include right assessment, right documentation, right report, everything you can involve, but keep TRAMP as the basic checklist, basic 5 rights for your medication administration. Next, basic thing that I would say is minimize distractions and interruptions. Now, if you see this picture, it's very funny. This nurse is giving a ambu bag resuscitation to the patient, but she's also checking her message, or maybe she's clicking a picture. I don't know what she's doing, but she's not supposed to have that phone right now. But she's having the phone in her hand. So she's so distracted, you know? So distractions in this day and age is common. We love our phones, we love our Instagram, we love our Facebook, we love social media, we love Googling, we love the information is available on the fingertips. So we love to click like this. And we easily get distracted and interrupted. So it's very important to know that you need to keep distractions away. So many hospitals don't allow nurses to carry phone when they are on duty. Good for them. It's good actually in a way to have that discipline so that we are not interacted and constantly thinking about the messages. But hospitals where mobile phones are allowed, I'm not saying do not carry your mobile phones, but use discretion, use your wisdom in using your mobile phones at the right time. Now, when you are resuscitating a patient, you don't use your mobile phone. It's not that urgent, right? So you need to know when you need to use your mobile phones. You need to know that you need to keep certain things for a later time. You can do it later. You can do it when you're chilling, you're resting, and you can check your messages then. But prioritize when you need to do what. So like CPR and like other crucial life-saving nursing interventions that you do, you also need to keep distractions away when you're giving medications because it is prone to error. Distractions can lead to error. Distractions can cause anxiety, lethargy, confusion, memory issues, and then you end up giving the wrong medication to the patient. So, no to mobile devices if you are using mobile devices while administering medications. Keep it away for some time. Keep it away for some time if it's not urgent, just keep it away. Give your medication to the patient, and then later on you check your messages. For people who do not use mobile phones on duty, good for them. Distractions can come in different ways, talking and discussing about personal things. That can be very distracting. Also, if roles are not clear where you're working, for example, in ACLS, if you have attended ACLS, you know that how important it is to know your roles. If there is role confusion, that leads to a lot of interruption, a lot of distraction. So these are some of the things that can lead to distraction. So you need to find out, each one of you, assess your situation, find out what is causing interactions and what you need to do. You need to take drastic steps to minimize interruptions, minimize distractions. Know the effect that distractions can cause you. It could be very stressful. It could be very distracting. It could cause confusion. It cause fatigue. So you need to keep minimal distractions while you're on duty. A special vest, apron, or sash. It's a very good initiative. I have seen few hospitals using a special medication nurse sash while administering medication. It's a very good practice if you have one. If you do not have, you can think about it. Anything unique, anything which is different, which can give your nurse the time and space to administer medications without interruptions. She is not supposed to leave the medication and go for rounds or do anything else. She should be solely prepare the medications and administer it, and nobody is supposed to disturb her till she finishes her work. So a special vest, apron, or sash would be helpful. Whenever you are administering medications, you have to keep your supplies and documents ready. All the medication, whatever, loading and cleaning, everything you have to keep ready, all the supplies and the documentation, the medication chart where you can recheck what medications are supposed to be given. Everything has to be handy and kept in a no interruption zone. So if you do not have a no interruption zone, this is something that you can implement in your work area, workspace, to have a no interruption zone where the nurse can go peacefully without any disturbance, wear her sash, go and prepare the medications without any disturbance, so that can minimize drug errors. Okay, if you do all this, that's very good. This is a very good basic thing. These are very basic things that you can follow. But as I said, these are basic. So let me go beyond basic, something that you can do apart from these things. Be especially alert during high-risk situations, such as when you're stressed, when you're tired, when you're supervising inexperienced personnel. So I'm not talking about a stressful patient or a stressful area. I'm talking about you. If you are stressed out, if you are tired, if you are mentally not ready to administer medications, please be assertive, raise your voice and say that maybe you might need help, or just for today you might need some off time, or some time, just modify work, like you can take a am I yeah, so you can take a lighter patient and relax for some time till you feel that you are better, in a better position. All this is done thinking in a bigger picture, thinking about the safety of the patient. You are enhancing patient safety by taking care of yourself. So please, if there are any nurse leaders in this group, please be considerate. Please start this mechanism of going and talking with your fellow nurses and seeing if they are stressed out, if there's something wrong with them, if they are sound in mind to give medications. This way, team leaders, you would ensure that your nurses are in the safe place, they are ready, they would be able to carry out the procedures without any distraction or without any stress. So please inform if you are in a very risky situation, in a dicey situation, and you're not ready mentally to administer medications. Please talk to your team leaders. Please be assertive here rather than making a mistake. Yeah. Have knowledge, know about appropriate antidotes, reversal agents. Yeah, so I'm sure you must be having a cabinet in your department with high alert drugs, with concentrated electrolytes. So you need to know where they are. You need to be well aware where they are kept. You need to know where are the antidotes. You need to know where are the reversal agents. For example, if there is an paracetamol poisoning and you need acetylcysteine for as a reversal agent to reverse the poisoning. For example, if the patient has been given an overdose of fentanyl, you need to know where the naloxone is kept. If there is a heparin overdose, you need to know where the heparin antidote is kept, right? So you need to know, you need to be aware about your surroundings. Nurses, take the initiative to learn your environment. What is kept in which corner? Where do you go when a situation like this arises? And it doesn't happen just like this. It doesn't happen with one induction. It has to be continual training and education and spreading awareness. So you need to know appropriate antidotes, reversal agents. Where are they kept? Are they under certain policy, lock and key? How do you get it when there is an emergency? High alert drugs. You need to know what high alert drugs are available in the hospital, but you need to specially know what high alert drugs are available in your own department. Now, when we ask nurses, are you aware about the high alert medications? Yes, yes, we are aware. Do you have a list? Oh, yes, we have 7 pages of high alert medication. That's going to create more confusion. Please choose the high alert medications that are commonly used in your department. Be aware about these medications. What are the actions? What can they cause? And train your nurses, team leaders, train your nurses. And nurses, please learn. Let us together be passionate, be curious about these medications and learn more about them. Where are they kept? Where is the key for high alert medications? How do I get them? What are the policies? Please get accustomed to these policies that are in place. Lassa drugs. Lassa drugs, I will not go in detail because I'm sure you all know what Lassa drugs are. Look alike and sound alike, and that can also cause medication errors. So I would encourage each one of us to know what Lassa drugs are available in your department and how often it is used. What are the actions? What are the side effects? And what do you do when a mistake, an error happens, or you need an antidote? So be aware of the Lassa drugs that are available in your department. There's also something called as tallman lettering. I'm not sure if this is implemented in your hospital, but tallman letter is something where it's visually safe for us to see Lassa drugs. Like they are specifically highlighted. If there are two sound-alike drugs, you see that those letters that are different are highlighted so that you're sure that this is not you are not confused between the two drugs. So this is a very general list, but if you could go back and make a list of the Lassa that you commonly give in your department, that would be amazing. So for example, bupropion and buspirone. So one is an antidepressant, one is an anxiolytic agent. Dobutamine is a cardiogenic drug, and dopamine is a catecholamine. So they sound similar. Okay, and there can be confusion if there is an inexperienced nurse, or if there's a new nurse who is not properly oriented. So please do have these policies in place that can avoid such a patient threat, avoid such kind of errors. Also, patient wait. So what used to happen whenever we used to come to clinicals, we were so lazy to, go and assess the patient wait. Whenever patient comes to the ICU, patient is not normal. Of course, you receive difficult and critical patients in the ICU. So we used to have difficult patients, and we were so lazy. So doctor would ask us, what is the patient weight? And we would just visually scan 62 kg. Is that right? That's not right. That is very inappropriate. That's a wrong practice. Stop guessing patient weight. Take the weight of the patient. Find out ways where you could. Could I request you to keep your mics muted? Yeah, find out ways where you can actually find out the patient weight rather than doing a guesswork, because that can mess up with your medication calculation, especially in the ICU, because most of the drugs in the ICU need patient weight. And let's not guess and play this game. Monitoring vital signs, especially if the patient is, for example, if the patient is receiving opioid analgesics post-surgery, like post-TKR, post-EHR, the patient is on a fentanyl cocktail. And the doctor says, oh, you have to monitor the vital signs. And I'm just monitoring temperature, pulse, respiration, BP. That's it. I just monitor. No, go beyond basics. Ask what happens if the temperature is high? What happens if the respiration is affected here? Is the medication causing low respiration in the patient? Is the medication causing high heart rate or low heart rate? Is the BP fluctuating because of this medication? Be curious. Know, learn, have that nature to know why it is happening, whatever is happening. Okay, that would help you to climb heights if you are interested, if you're curious to learn what is happening, whatever is happening, right? So you need to monitor vital signs. You need to have your critical thinking cap on whenever you are monitoring these kind of high alert drugs and lassa drugs, and see why changes are happening in the patient. Was the patient drowsy before I gave the medication? Has the patient become drowsy after I administered the medication? Is my patient a vulnerable patient? Of course, yes. So then he needs extra care. So you need to be very vigilant and very alert when you are administering medications, especially high alert medications to the patients. Infusion device. I know we all use infusion device in the hospitals. And the sad part is that when a new nurse enters, sometimes she is hesitant. She doesn't know how to use it. But then we take it for granted. We assume that, oh, she should be knowing it. But let's not take it for granted. Let's not assume that everyone knows everything. Let's have continual trainings on how to use infusion devices. Arrange it with your um, biotechnology team, and get them involved and get the nurses trained with the infusion devices, how they are supposed to use. Because if you do not know how to use it, you might fatally harm the patient. So it is better to admit that you do not know rather than saying I know how to do it and then ending up harming the patient, right? Reconcile the patient's medications at each care transition and whenever new medication is ordered, to reduce the risk for medication errors. That includes omissions, duplications, dose errors, and drug reactions. So reconciliation is not purely nurse's job, not purely reviewing the medications, not purely the nurse's job, but we are a part of this process. And I would encourage you, rather than putting your hands up and saying I'm not going to bother, no, be involved, get reconciliation with the team for the patient's medications if it is not already done. Check the medications at every care transition. Talk to the patient when the patient is getting discharged. See if there is any medication that was there and it's omitted now. If there is a double dose, like double intending of medications, if there is dosage errors, if there are two medications that can interact when they are together and can cause damage to the patient. So reconcile and review your medication charts time and again. Let's not take granted that, oh, I have checked it once, so it's fine. No, have that attitude, have that habit of checking and rechecking the medication chart and discussing with your reconciliation team. Educate and provide written instructions to the patient and family regarding prescribed medications for use when at home, and verify their understanding. So I remember ma'am had shared a very crisp document about talking to the patient, whether they have understood what medications are there and how to use it, what are the side effects. If you just spend some time with the patient and the relatives about this, that would reap benefits to the patient. In our caregiving, the nurses change, the doctors change, the pharmacists change, everyone changes, but the patient remains the same. So it is very important for us, even if we are having 10 patients and same drugs for all 10, similar drugs for all 10 patients, we have to talk to each patient, because each patient has a different experience, has different knowledge and comprehension. So it's very important for us to talk to each patient about um, drugs, especially when they are taking discharge, because vulnerable patients, geriatric patients, they suffer a lot if it is not done in the right way, and they end up overdosing, underdosing, and that can lead to death. Right? So that's all about going beyond basics. Now let's talk about to err as human. So Madam Thangam has been talking about this in last several 2-3 sessions, that to err as human. Yes, making an error is not something, not something, oh, out of the blue. Mistakes do happen. We need to accept that mistakes do happen. We need to be transparent about those mistakes. But to cover it up is unforgivable. We are causing a great damage to ourselves, to the patient, to the system, to everyone. Like, we are representing this particular hospital, this particular ward. We are causing damage to everyone when we are trying to cover up the mistake. And to fail to learn from that mistake is inexcusable. You cannot say that, oh, it happened, oh, it's happening again. No, it's not. It's not easy to give this excuse. You are playing with the lives of the patient, right? In 2000, the Institute of Medicine released "To Err is Human," which asserts that the problem in medical errors or medication errors is not because of bad people in healthcare, but it could be because of good people who are working in bad systems that need to be made safer. So let us not put our nurses, let us not be in the guilt trip that, oh, I committed a mistake. Let us understand that you are not the only person who are responsible to commit that mistake. There is a whole system that covers you, and we need to analyze what went wrong where. Okay, so stop having those guilt trips and stop putting people down that, oh, it happened because of this particular nurse. Rather than shaming and naming, let's find out what are the causes for this particular medication error happening. Right? So there are 8 recommendations for achieving total system safety. Number 1, ensure that leaders establish and sustain a safety culture. Okay. Now, most of y'all are, I'm assuming most of y'all are nurses, staff nurses, and you work under leaders. So I would encourage you all to ask for a safe culture, to be assertive and push back and ask for a safe culture when you're working. Do not take everything as it comes. You need to prioritize your safety in order to prioritize patient safety. If you are not okay, the patient would not be okay. So I would encourage you, do not blindly follow um, um, whatever is being told, whatever is being demanded from you. If a doctor is just in a hurry, he's prescribing a medication and is leaving, you have the right to ask, excuse me, this is not clear, could you write it again in clear language so that I don't commit an error? Please have that assertive behavior to push back and do what is right to sustain a safety culture. Okay, so ensure that you are in a safe culture. If suppose tomorrow you have been given 10 patients and you know that this is going to be very stressful because earlier it was stressful and you committed an error, you almost committed an error, and this is happening again, you need to push back. You need to stand your grounds and say, excuse me, I have 10 patients. I am going to end up, there is a chance, there is a slight chance that error could happen. Could you please send me one help? Could you send me someone that can relieve me from this burden and help me distribute responsibilities and give and focus on the patients by preventing medication errors? So ensure that you are having a safe culture by talking to your leaders, by being transparent about your struggles. Create centralized and coordinated oversight of patient safety. So yeah, there is a team of patient safety and you are not always a part of it, but you as an individual can hold yourself accountable and responsible to oversee patient safety. If you are working in a small department, there are 4 nurses working alongside you. Be a change maker, be the leader, ensure that all of you are following patient safety measures. Okay, and coordinate, overlook, check, recheck, and prevent any kind of patient medication error. Create a common set of safety metrics that reflects meaningful outcomes. Now, this I would say would mostly go to the leaders, the people who make protocols, and so it would go. This point would be basically for them. Increasing funding for research in patient safety and implementation science. Yes, we should have researchers which are very transparent and open about near misses, adverse, and sentinel events, so that from there we would have data, we would learn from that data, and we would come up with measures that can prevent these kind of errors and enhance patient safety. Address safety across the entire care continuum. Like you need to address the importance of safety by continual planning, continual training, continual updates, continual assessments, and by that you will ensure that the safety measures are addressed and they are followed. Support the healthcare workforce. So here we need to support each other rather than putting each other down that, oh, you did an error, let's not talk to you. No, let's not have that discouraging and putting down mentality, because an error can happen with the best of nurses. With the smartest nurse, the error can happen. So let us have a supportive culture where we support each other, we help each other to follow safety protocols. We make it as a habit to help each other, remind each other that we need to follow these safety protocols to enhance patient safety. Partner with patients and families for the safest care. As I told you, people come and go, but the patient remains the same. The patient has multiple nurses, morning, evening, night. He has multiple nurses, multiple doctors come, but the patient remains the same. Take this opportunity to talk to your patient about the medications he is receiving, the route, the dose, the time, so that you are also sure that you are passing on the right information. And by reviewing the document again and again, you are also aware that these are the medications, and if you have the eye for detail, you will quickly be able to find out if there is any error in that. Okay, so partner with patients and families for safest care. Ensure that technology is safe and optimized to improve patient safety. So whatever technology you're using, I have seen hospitals where they use small tablets to ensure medication administration documentation. Very good. But there are people who are not techno savvy. So if you are in a place where you're using a hospital information system, or you have iPads or iPhones and you're doing system entry, okay, be familiar with those technology. Ensure that you know what you're using, you know how to handle this particular device. Now, get yourself trained, get yourself aware that how you are supposed to use this technology for your betterment and for patient proper a safety outcome. You need to be aware about these kind of technology that are available. But the thing is, in spite of everything that we do, sometimes errors are inevitable. Okay, we can't pinpoint to a particular nurse, we can't pinpoint to a particular system or protocol or policy, and nurses are bogged down by that. They are scared, and these kind of errors are category A, B, C, as you saw in the previous slides. They are underreported. We don't take it so seriously. And why? Because there is lack of awareness that a medication error has occurred. If we are not aware that these are the categories of medication error, even in working in a high risk area, and almost committing an error is also an error. If we are not aware about this, we would not know what medication error is. We would think, oh, I gave the medication, nothing happened, so let me just brush it off. So we are unaware, or sometimes we are ignorant that this could be a medication error. We are unfamiliar with the error reporting processes. Sometimes we are not oriented to it. Sometimes we are oriented, but we forget, we are not interested to follow up. We are not curious enough to know, oh, what are the reporting processes in place? Okay, so unfamiliarity. Sometimes nurses in the sense, we all fear legal ramifications. What if I'm dragged to the court? What if something happens to me and my family? Sometimes we fear of disciplinary action. What if I am fired? What if I am moved from one department to another? Okay, fear of being perceived as incompetent. Okay, sometimes, people might think I don't know things, and that's why they are not giving me more responsibilities. They might not give me more responsibilities if I report it. So these are the challenges and the fears that are faced by the nurses. And here is something that we can bring change. We can bring change in the attitude, in the mentality, in the way we think that a particular nurse is responsible. So let me talk about Swiss cheese model. If you see, I'm sure Tanga madam has already dealt with this in the previous class session, but let me just go through it once again. So this is a Swiss cheese. This cheese has multiple holes, if you see. So there are multiple layers of cheese that are placed. And these indicate the safeguards that we have in our system. Okay, so we have certain defenses that we have in place to protect ourselves. We have protocols and procedures in place. We have continual trainings that happen in our hospital. We have systems in place, and we have work culture. Now, there are gaps. If there are gaps in these, like if there are procedures and protocols, but they are incomplete or not in action, or only done when there is a JCI audit or an NABH audit, and this is not done on a regular daily, it's not a regular habitual thing, then that can go wrong. Okay, so that's a loophole. If you have procedures, but that is not followed. If there is training, oh, we have documented that 7 hours of training per nurse, but that training is done just for documentation. Okay, I know many institutions where training is done just for documentation. And in spite of all the training, all the reassessments and everything, there is lack of understanding, there is lack of knowledge. Okay, so that is again a loophole. System in place. There is a system in place, but there are so many loopholes. It's a poor compliance. We are not complying to the system that is in place. There is a work culture, but there is no clear leadership. There is no team structure to help you, to support you. So if all these loopholes are there, an error can happen. So it is not a particular nurse to be blamed. It could be because of procedures that are not in place, or it is incomplete and she is not aware what needs to be done, what is the action to be performed. If there is training but she is not receiving information, or not updated properly about the medication processes, or LASA drugs or high alert, there is a loophole. If there are system in place, there is a work culture, but it is a very poor setting, that can all lead to error. So a nurse is not solely responsible for medication error. It is a group of factors. So how do we deal with this? By understanding human factors. So according to JCI, 73% of medication errors happen because of human factors. You know that? Suppose if, as I told you, suppose if a nurse is having an evening shift, and then she's called and she's told, you have to come for the morning shift as well. She comes to duty without eating, without drinking. She just comes there because she's scared, and she has to be there because there is staff shortage. Now what happens is, she's empty stomach. That would lead to previous night's exhaustion, plus empty stomach. That would lead to less poor attention, poor concentration, and there is more chance of error here. Okay. Also, when two people meet, we talk about random things, and talking random things might be inappropriate when we are in the healthcare setting. So we can talk about these things later and prioritize what needs to be discussed when we are in the work setting. So it's a human factor, but we need to work around it, how we can make it better. Okay. Also, as I told you, drug calculation, human factor. Sometimes we are not very savvy with drug calculation. It's a struggle to multiply and divide and, into 100,000 and all, and find out the formula and the decimal and everything. It's very difficult for some people. So understanding that factor and training, identifying and training that particular nurse, by being patient, by being sympathetic, and by providing information, can actually help. So we need to understand the human factors. We should not overlook or underlook these factors, but give importance to these factors. Understand that this is something that is there, that exists, and we need to work towards it. Okay, so understanding human factors. And by understanding human factors, we can play a huge role in providing knowledge about medications and systems in place. So ideally, we need to know the pharmacodynamics and kinetics about the medications. But I'm not saying that you need to know the pathophysiology and the mitochondria and the cell and how it works with the DNA. No, you don't need to know that. What you need to know is the ward or the ICU that you're working in. What are the medications commonly available in the cupboard? What are the medications your patient is receiving? If there is a new medication, be curious. Be wanting to know what medication this is. Ask your doctor. Ask your doctor who has prescribed this medication. Be curious. Don't be afraid that, oh, what will he think about me? That's fine. That's fine. That's going to help you over the years. There is no harm, no damage, no ego damage when you ask a question. That in fact shows the curiosity in you to learn more, to update yourself. You are looking forward for patient safety. You are looking to minimize medication errors. So don't be very quiet and do whatever blindly has been instructed. Have that energy in you, have that mentality in you to ask more questions. Okay, have more knowledge, have a drug book with you. If you have space in your pocket, you can put your mobile outside, put a drug book inside. That would be more helpful for you to check what medications are going on for your patient. Not only the action, but the side effects, the implementations. Also, you can ask the doctor, what would be the possible side effect if I give this medication to the patient? For example, if you're giving multivitamins to the patient, the urine is supposed to be yellow in color. But if you do not know this, and the next day you report it to the doctor, oh, the color of the urine was very yellow, and the doctor would be like, yeah, because he was taking multivitamins. So these are common things. These are things that you can already know, and then keep it with you, keep this knowledge with you, and utilize this. So don't have knowledge, but apply it into wisdom when you're working. Okay, so have knowledge about medications and systems in place. Know what you're supposed to do when an error happens. Know how you're supposed to report it. Be transparent. Be the first person to report it and admit the mistake. Okay, so these things can help you. So having knowledge about medications and system in place. Third thing is by recognizing perpetual factors or minding inattentional blindness. Now, this is a very interesting factor. So perpetual factor matlab whatever has been forever, like wherever you're working, some factors remain forever. So because of those factors, you function in the same way day in and day out. Now, you must have heard familiarity breeds contempt. When we are so familiar with something, we are actually taking that for granted. We are assuming that we know it. So sometimes our brain can play that trick with us. It can actually filter out some information, and it can cause optical illusion in our mind and make us believe what we want to believe. Now, let me not complicate it for you. I'll give you an example. If there is a crash trolley, and you know that drawer number one has atropine, drawer number 2 has adrenaline, drawer number 3 has epinephrine. You might have the tendency to open the drawer, just close your eyes, just pick up the second drawer. If your doctor is advising for epinephrine, you blindly take up the vial, load it, and give it to the patient because you're so used to doing this day in and day out. And also, it's a habit that has been formed, right? So do not fall for that. Be very aware, mindful about inattentional blindness. You might not be doing it purposefully. It is a habit that you create. So have the habit of following the protocols and policies from the start. If you have not been in that habit, start it right away. Do it as per the policy and the protocol. Do not do it just how you feel like doing it, because you might end up committing more errors because of inattentional blindness. Remember, Madam had shared about an incident where a nurse administered Verised instead of Vercuronium. Now there she put it in the system and she overrid the system, but she put VE, and whatever came first, she just took it and gave it to the patient, and the patient died. Right? So your inattentional blindness might cause might cause nothing or might cause major damage. But why do we have to do that? So let us form new habits. Let us unlearn some things and let us learn some habits that can help us in the future. Let us not wait for some audits to happen or some checking to happen to go read back the policy and do it. That is not the right way to do it. Do it even when nobody is watching you, because you are accountable not only to yourself or as a patient, you're accountable to God as well. He is watching you if nobody else is watching you, right? So have the habit of following the protocols, whatever process or protocol is in place. Do not wait for the last minute auditing to happen, because when audits happen, we panic, and we are not used to following the processes all the time. So we goof up, we make mistakes. So this is a good advice from me, that follow the protocols no matter who's watching, and have the habit. People will watch you. People would learn from you. People would consider you as the change maker, as the role model when you are doing the procedure when nobody else is watching, right? So these are some of the factors. Let me talk about personal accountability. We talked about to err is human and errors happen, and it's not the only the nurse's fault, but it's the system that is in place. Okay, that is all true. That is perfectly fine. But let's not forget that we also are personally accountable, personally responsible to follow the processes and protocols that are in place. Okay, so personal accountability is of great importance. High risk situations, you need to know what high risk situations are. You need to know there is a transition of care. What are you supposed to do when there is a transition of care? You need to know what polypharmacy is, how you deal with a patient carrying 5 to 10 medications. How are the drug interactions? Are there repeated doses? Is something omitted? You need to know these things. Okay. So you are accountable to learn, right? So sessions like these, benefit from it, learn from these sessions where the information is fresh, the information is very helpful. Like in the previous sessions, Tanga madam was talking about polypharmacy, transition of care, high risk situations. If you have the time, you can go back and listen to these sessions once again, and you can implement these things where you are working. So personal accountability, know your medications, whatever medications your patient is receiving on the bedside or wherever it is. You should know what medications are going for your patient. Know the actions, know the side effects, know the mechanism of action, know the nursing responsibility. Ask your doctor, what should I look for? What are the changes? Write down the special considerations. What should I look for? Ask for those extra information from your doctor. Check that you're using the right medication the right way. Use TRAMP. Right time, right route, right dose, right medication, right patient. Check for allergies. Check for use two identifying identity to cross check if you're giving the drug to the right patient. Okay, so check, recheck, keep rechecking, right? So that you can prevent medication error at every step of the process. Ask. Here is where we all hesitate. So I was telling you the nurse who loaded tramadol, Tramazac, and was about to give it to the patient. You know, if if he would have thought, oh, let me ask someone before, that would have helped. That would have saved so much of damage that happened, right? So ask your healthcare professional, your doctor, your senior team leaders, your nursing in charges, like what are these medications? How does it help my patient? What should I look for? So ask and gain information and use it wisely. Be vigilant when you're preparing medications. You need to know whether these are high alert, whether these are LASA drugs, how you need to prepare, what should be the dose, what should be the route. Always clarify when you are in doubt. Do not assume that you have done this for 5 years and so nothing can go wrong. That can be because of, that can inattentional blindness can lead to that. So do not do blindly. Always clarify, always cross check with someone if you are in doubt. Use two patient identifiers at all times. Use your patient's name, use your patient's UHID or MRD. Always follow policy for patient identification. Whatever policy is there in your hospital setting, please stick to it. Please don't take these things for granted. These are really important to ensure patient safety. Avoid workarounds, shortcuts. Let's not do that. We are nurses, we are healthcare professionals, we are called to act professionally. Let's not use shortcuts to make our job easy. Let us do whatever is according to the policy and the procedure that would enhance patient safety. So let us not use shortcuts. Let us not grab medications from our neighboring patient and give it to our patient. Let's not do that. Let's follow the process and protocol. Be diligent in all medication calculations. If you do not know medication calculations, reach out, get yourself trained, read, practice. You are personally accountable to know. People will teach you, but they have a limitation. If you don't have that in you to learn more and practice and put it into action, then then you're not showing accountability. So if you are administering a dobutamine or a dopamine or an NTG, where are the patient, where in which area, in which formula do we need weight? You need to be aware. You need to practice and practice and practice to avoid medication errors. Avoid reliance on memory. Use checklists and memory aids. See, we are fallible in nature. We make mistakes. I have got a phenomenal memory, but honestly, I would not want to rely on it because I can end up making mistakes. Okay, my memory is not perfect or fallible. So let us not depend upon our own memory and I know everything, I can do this, I got this. All that is fine. That confidence is good, but please check, recheck when you are administering medication to the patient. Communicate with your patient before and after administration. I've been reiterating this, re-emphasizing this factor. Talk to your patient. Do not go in the room with the medication syringe, just put it, just blindly push it, put the cork, come back. No, talk to your patient. I am giving this drug to you. You might find certain tingling on your arm or the injection site. You might feel flushes. Talk to your patient. Discuss about what medication you're giving and what the patient would feel after the medication, just to ensure that everything is in a proper place and that your patient is aware what he is receiving. Ensure medication has not expired. Sometimes it happens that you receive medications that are expired and we don't check the medication expiry and we end up giving it to the patient. Though it doesn't happen a lot because many hospitals have good systems in check. The pharmacy personnel keeps checking the medication expiry date, but it's not that it's inevitable. It could happen. So please check the expiry date of your medications. Assessment comes before medication administration. As I was telling you before, if a patient is already having a potassium level of 3.5 and your doctor comes and says, he might have not seen the potassium level, and he comes and says, okay, sister, please give 40 mg Lasix to the patient, make it a BD dose and give it for 7 days. You should not blindly take it down. Be a bit more interactive when these kind of orders are given. Okay, sir, I understand that your response should be more like, I understand Lasix is a potassium loop diuretic and potassium can deplete further if I'm giving Lasix to the patient. Are you sure you want BD dose, you want 40 mg to be given twice a day? Ask questions. Ask questions. You might be wrong sometimes. That's fine. There is no harm in asking questions. Always assess before you are giving medication to the patient. I remember I had a patient once and he had nephrotoxicity and he was having pain, and the registrar did not check the diagnosis of the patient. He just heard, oh, I'm having pain. The patient said, I'm having pain. So the registrar said, okay, sister, just give him paracetamol, usko de do, 1 gram stat. And I said, sir, I think you need to reconsider because the patient has always the patient is already having nephrotoxicity. This might interfere with his further kidney function. Should we give him paracetamol? He looked at me, he went, then he came back and he said, okay, sister, just omit that, we will give him something else. So there is no harm in asking, right? You have prevented further damage to the patient by being a bit alert, right? So asking questions, assessing before giving the medication. Does the patient need this? Is this medication necessary? Has the condition improved or do we need to give this medication, right? So assess. Do not blindly keep giving opioids and analgesics to the patient. Administer the pain levels. When you're giving sedation, antisedatives or sedatives to the patient, monitor the sedation levels. So be proactive in assessing your patient before giving medications and do not do it blindly. Use available technology. Again, as I'm saying, we are not naturally technology savvy. Okay, these days I can say we are very good with using our mobile phones, but sometimes you have HIS in place like Oracle or something, and it could take a while to learn to get accustomed to the HIS system of your hospital. So learn whatever opportunity you have, learn the technology and use it while you're administering medications. Report. I encourage you all, report near misses, adverse reactions, and events that happen, sentinel events that happen because of medication administration. Let's not hush it up. Let's not have that culture. Let's be accountable. Let's be transparent in our work. Be alert to error-prone situations, either the situation that you are in, okay, you know that you are not mentally ready, or situations where you are placed in an error zone where you have vulnerable patients one after the other, you have pediatric patients, geriatric patients. So be aware of the high alert medication, about the error prone situation. Be aware about the high alert medications that you are administering to the patient. If a patient questions or expresses concern about a medication, stop and do not administer it till you clarify it. Do not force it on the patient. Like, oh, you keep quiet. I know this is for your good. And just, no, do not force. You need to answer. You need to be answerable to the concern that has been raised. Stop. Talk to your physician. Talk to the doctor who has prescribed this medication and then only administer. Most importantly, ask for help. If you think that you are overloaded, you are burdened, you are in a high risk situation, do not hesitate in asking for help from your seniors, from your team leaders. And team leaders, I would encourage, when someone asks for help, please provide them help so that you can further enhance patient safety. You can reduce the amount of errors that happen because of these things. Last but not the least, nurses are the last line of defense. We have the doctors who prescribe medications. We have the pharmacist who would transcribe and then dispense the medication. And the medication reaches to the nurse. She receives the medication and she is the last in line to receive that and administer directly to the patient. So she is last line of defense and it all depends upon her. So we are the last line of defense when it comes to medication administration. So let us buckle up. Let us gear up. Let us take this as a huge responsibility and be personally accountable when we are administering medications to the patient. Let us make this a goal. Whenever we are handling medications, we need to be extra alert, extra sure that the right medication is going to the right patient, right? I would encourage a culture of safety. Nurses, let us fight for our safety. If you think the situation is unsafe and that makes you prone to commit an error, be transparent about it. So in that way, you are creating an environment of safety. Yeah. Report your errors. Talk to your team leaders. Report as many errors as possible, and let that be a learning for every nurse, for each and every one, to be more careful before another error happens, right? Let us follow the no name, no blame, no shame culture. Like, let us not sit and crucify that particular nurse who has committed an error, because to err is human and it can happen with the best of nurses. So let us not particularly send people to guilt trips and make the person feel miserable because of the mistake, but let us encourage, let us analyze the situation, find out the root cause, work on the root cause, and encourage nurses who are working so that we can discourage these kind of errors. As I said, learning from errors. To err is human. To hide the error is it's another level, and to not learn from those errors is also not right. So please learn from these errors, but unless you do not project these errors, unless these errors are not notified, how would you learn from it? So I would encourage you all to be transparent while you are reporting errors. Be transparent about it. Follow the processes and policies that are in place. Individual accountability. Even if it's inevitable to err, you are fully responsible as a healthcare worker, as a last line of defense, to provide safe medication administration to your patient. So take it as a high calling, as a high responsibility when you are in your field. It's a battlefield. And we need to be vigilant. We need to be alert. We need to be alert of the situation. We need to be alert of our own circumstance, and we need to administer the medication with safety. also continual learning. So platforms like these, which would help you remember remember certain policies and certain ways where you can improve patient safety. Try to always get yourself into continual learning, updating yourself with knowledge and understanding so that you can apply that wisdom at workplace. So these are some things I would encourage each one of you to do. So I have discussed about basic things. I have discussed about going beyond basics, to be mindful about the nurses, to be mindful about each other when you're working in a team, to help each other, to identify high risk areas, high risk behaviors, to be considerate to each other, to understand that it is not an individual responsibility, but it is a system that is in error, and being individually accountable also about medication safety. So I've discussed all these things, and I hope it was helpful for each one of you. I'm glad if you would be able to implement some of the things that I have showcased here. Even the smallest thing that would help you to enhance patient safety would be a gain. Yeah. So thank you so much. Stay safe, stay positive. If you have any questions, the session is open for you. You can ask your questions. Madam is also there with me to help me, so we can answer your questions. You can put your video on if you would like to. So thank you so much.
Thank you very much, Lindsay. And there is a lot of congratulations coming your way in the chat box. So thank you, because you were able to explain in a manner that everybody can understand and relate to. That's a gift from God. So I would only say continue to hone it and use it for the benefit of nurses and patients. I'm really very touched. I'm very happy that I have introduced you. And yes, I will tell the team here, you will see more of her for sure. And I will do my best to bring her and showcase her. And thank you very much for all the, congratulatory note. And most importantly, I really hope that all of you have decided, especially the nurses and the students, that you're going to do something different from today. I mean, that is the high point of the session. Congratulatory notes are always very good. Okay. So I'm just reading this book. So there is a quote I would like to read from. This is a book of quotes, this is written for daily inspiration for women, but it's inspiration for everyone. And it is so close to what Lindsay had been telling us. We ought to be able to learn something secondhand. There is not enough time for us to make all the mistakes ourselves. Isn't it such a powerful thing from Harriet Hall? And in healthcare, this is very, very important. We cannot learn by making our own mistake. The error is human, cover it up is unpardonable. And not learning from someone else's mistake, I would say, is definitely stupid. So I would always urge nurses, students, and leaders, let's share as many mistakes as we hear, see from each other, and let's learn from each other. So thank you so much, Lindsay, and thank you all of you for being here. Let me make an announcement. Watch out for all these 5 videos. There will be quiz competition sometime this week. I don't know when. We will tell you the dates. There will be one prize for nurses, and there'll be another prize for a nursing student. We will tell you the details. So that would mean that you have to go back and look at all the videos, because the questions are going to be from those video sessions, not from any book or anywhere. Whatever has been discussed. So from there will be questions. So that's an announcement. And the prize is going to be a cash prize as usual from Cygnia Healthcare. Every year we give out cash prize during the patient safety week. So we are going to do that this year also. So watch out for details. So thank you, Lindsay. Thank you once again. And before you go, let me just stop the recording. Thank everyone for being here. And I will